Hey guys, good afternoon. Can you hear us?
Yes, can you hear us?
We can hear you loud and clear.
We hope we saw you dancing to our music for our video.
I like that video. That was good.
Yeah, we can see we can see you from here too, unusually. So that's good for us too. But welcome to Atlanta, and welcome to the Piedmont Heart Institute. Thanks so much for the opportunity to share with you this case, and we look forward to some interesting discussion and your input on the case itself. It's an honor and privilege, as usual, to be here with my good friend and colleague, David Kandzari. And we have our cath lab team here. We have Stefan, Lenny, Chad, and at the monitor we have Cassandra. So thank you to you all for everything that you do, not just today, but every day. So thank you. Without you, we couldn't do this. So Michael, let's just take a look at our slides here. We've got a brief case introduction presentation for you, and then we'll get into the meat of things here. So just to kind of put things into perspective, this is our new building. Forward, next slide, Michael. So we are about 10 minutes north of where you guys are, about 5 miles north of the Hyatt Regency, just to put things into perspective. So not very far away. Next slide. And yes, feel free to drive in. And again, just a shout out to our team, without whom we would not be able to do any of this or do the work that we do here. So thank you to the great work done by our cath lab team. Next slide. So this is a 59-year-old gentleman. He has the usual coronary risk factors of hypertension, hyperlipidemia, type 2 diabetes mellitus, who presented to us with progressively worsening exertional chest pain despite 2 antianginal therapies. He underwent a nuclear perfusion study that showed significant anterior ischemia. Next slide. So he underwent initial diagnostic angiography a week or two ago, and we saw a sort of a left dominant, or at least a co-dominant circulation, and a very severely calcified proximal to mid LAD. And so we decided we'll bring it back for for this live session. So our indication here for PCI is a progressively worsening exertional angina despite 2 antianginals. And I think we're going to have a little bit of a discussion about the appropriate treatment strategy for calcified lesions. So let's go to the next slide here. So these are the diagnostic pictures from a week ago. So AP caudal on the left, and you get a sense of the high-grade stenosis in the proximal LAD. And on the right, the AP cranial view. So David, let me stop for a moment and let you come and comment on the anatomy here, and then we can discuss sort of our strategy for dealing with calcified lesions.
Yeah, so a welcomed opportunity to be with all of you again, and good to see many of you, if not but virtually nearby. The indication would be, of course, not only accelerated angina symptoms, but proximal left anterior descending artery disease. And we'll give you some better images, perhaps, or a little clearer, perhaps today too, just with the diagnostic angiography. But of course, there's moderate proximal circumflex disease, though I don't think significant and not hemodynamically significant. And then with regard to the proximal LAD, this AP cranial, among other views, will really highlight that you've got, so to speak, train track outline of the vessel with calcification. And the calcium extends from the very proximal segment, at least to the level of that first diagonal branch. And then there's still more significant narrowing beyond that area of what might be post-stenotic dilatation. And that doesn't, at least fluoroscopically, appear to be so calcified. But the short of it is I think we've got concentric rather than nodular calcification in the absence of confirming by imaging. And I think this is a vessel that would not respond well to just traditional measures of high-pressure balloon angioplasty alone, though one might consider that as an option. We were thinking more of a plaque modification strategy, but we'd like to get your thoughts as well with regard to what approach you may take as well with the options of orbital rotational atherectomy and then intravascular lithotripsy.
And just move forward one slide, Michael. And just for the sake of completeness, left ventriculography showed normal LV function. We've rechecked an LV EDP just a short while ago, and his EDP is 20. So normal LV function, good EDP. We have adopted a right radial approach. We have a 6/7 slender sheath in the right wrist and a 7 French EBU 3/5 guide situated in the left main. Next slide, Michael. And so here's a sort of an overview, and I think, this is our last slide here before we can go on to the case itself. This is one sort of overview, if you like, of how to deal with this. A number of people are now adapting and sort of looking at this in slightly different ways. But what you'll notice is the algorithm, most algorithms in 2022 now start with some form of intracoronary imaging. And I think that's key to understand which of these sort of pathways you're going to take. So let me stop there for a second. I think that's all we had to say by way of introduction. I'll give it back to you guys on the panel to see if you had any other questions for us or other thoughts before we proceed here.
So if you can go back to the angiograms.
Let us actually show you today's, perhaps.
Yes, Cindy, I'll show you today's.
Get a little bit better image.
Yeah, so Michael, just show us the fluoro here now. So this is our AP caudal here. You can see there is an osteal landing zone, so relatively preserved ostium of the LAD, high grade beyond that. And then here's a spider view for you. There is there's a diagonal, not particularly big, but it's there, so that may come into play. And then here's the AP cranial view.
Okay. So it's helpful to have different views because the ariocaudal looks like it's, deep calcium or even epicardial calcium. And then these other views, of course, show the train tracks, so it's more concerning. So let's go through the panel. David, how will you manage this?
Yeah, I think we talked about this a little bit before. Yes, everybody agrees you ought to IVUS. Yes, everybody agrees no imaging catheter will cross this tight lesion. So the issue for me is, do you put a roto wire done now and just burr it and then IVUS afterwards? You take a non-compliant balloon and dilate and IVUS afterward IVUS afterwards. So I'm curious what everybody else does.
Yeah, I would probably wire it and see if you could get a balloon to cross and then see if you could get an imaging catheter to cross. I agree. It's very likely that an imaging catheter will not cross, in which case I think you actually have options for, you could practically use anything here. I feel like either orbital or rota or lithotripsy.
Right. It's actually kind of a straight shot, though, so I'm more optimistic than on some of those other cases.
Yeah, that's right.
Rajiv.
Yeah, David, PK, great case, and excited to see this. I guess I slight differ just because being fun on the panel to be different here. I think I would do an IVUS here, even if you can't cross the lesion. I feel knowing whether, Cindy's question, is that deep wall calcium proximally or is it all interval calcium? I'd kind of like to know that even if you couldn't cross the lesion. I think it might refine my strategy. So that's what I would do.
Yeah, and no, sorry to interrupt. I was just going to say that the inability to cross with IVUS notably is one of our criterion, like in the Eclipse trial, for instance, in which we're randomizing patients to atherectomy versus more traditional high-pressure balloon inflation strategies. So that in itself is a predictor.
Yeah, I was just going to say, I loved your flow chart. And what I would do here, I agree with the rest of the panelists here, is I would try to get a small balloon across there just to facilitate imaging, because I think it really does help you to know the morphology of the calcium. If it's deep calcium, if you find that there's nodular calcium, that might kind of help you choose. And I think that, there are options for any of the plaque modification strategies, but I think that'll really help you kind of choose, hopefully, the best one. Based on the calcification pattern.
Great.
I might be a little naysayer, but you may just do a primary rotational atherectomy strategy, and then small balloon, and then IVUS, and then you could always rotoshock. And I don't see a big drawback in that in terms of the algorithm.
All great ideas. I think we're all on the same page. Let's, just in the interest of time, let's show you what we ended up doing. So we wired this, and of course, here's how far the IVUS catheter would go. But to Rajiv's point, it did give us some useful information. So, Michael, if we could show the IVUS, please.
let's start at the beginning.
How hard was it to wire, PK? Was it
It was
straightforward?
Yeah, it was straightforward. This is a workhorse wire that we have here. It's a Minamo wire that we've taken down, and it was fairly easy to wire this. But you can see where where the IVUS catheter would not go any further, and that's the sort of closer to the left main. But then
notwithstanding shadowing from calcium, what's interesting is that this is really principally intimal calcification. There's not deep wall calcification. There's not deep nodular calcification either. Certainly nodular would lean my strategy toward more atherectomy here, but we've got truly a 360-degree arc of, there you go, of at least in this segment, but not deep adventitial extension.
So what we're going to do here is we are going to use a Scoreflex balloon. So this is a relatively new balloon. David here was involved in the pivotal IDE study with that, and we were a large enrolling site here. And it's basically a non-compliant balloon. It has the highest rated burst pressure of any of the specialty balloons that we have on the market currently. With an integral nitinol wire that's on the balloon itself, which is engineered into the shaft of the balloon. But if you'll notice, it has a very, very short RX segment. So the wire exits the catheter shaft distal to where the balloon is. So it doesn't kind of go through the balloon itself. And then the workhorse wire itself forms the second scoring element of the balloon. So we have a 17520 Scoreflex balloon here that we're going to see if it crosses. And that's going to be our initial strategy to just make some space. And then to Nadia's point, see if we can get the IVUS down and get some more information before our subsequent modification strategy.
So this focused force technology balloon, you can see just in the last image here, there's the balloon component, and then there's the external wire component, and then of course the guide wire component too. And it's very similar. Dave, Cindy, you'll recall on perhaps the FX mini rail, very similar to that technology.
Yeah, that didn't work, so I'm glad that this one does.
Yeah, what's especially nice about this technology is that the balloon itself is quite non-compliant.
Yes, it has for a specialty balloon, I mean, the comparators are obviously Chocolate, Angiosculpt, Wolverine. It has the highest burst pressure of any of those, and it has a burst pressure at 20 atmospheres.
I think Dave's just trying to point out how old I am. I'm probably the only person who's used FX mini rail in the audience.
So Dave, if you did not have this balloon available and you saw that napkin ring of calcium, would you try atherectomy first?
Yeah, for myself, I think the likelihood that went across.
So I just signed that for you, just so you had a clear picture of the crossing profile and how easily it went across. I mean, I would probably hasten to say that the Angiosculpt or Wolverine or any of the other balloons probably would not have crossed so easily. But let's see how that behaves. So this is the 17520 Scoreflex.
But
you're saying you already have enough evidence to move forward with atherectomy, perhaps?
Yeah, I think that if you look at some of the IVUS recommendations, if you have more than a 360-degree arc of calcium, it's usually atherectomy is my algorithm.
Right.
Yeah, I think so, Cindy, too. If this wouldn't cross, if it wouldn't dilate, I think that would be the next step is just to move forward with atherectomy itself. This actually, for what it's worth, looks like it's expanding again, noting it's only 175, though.
And you can see now the balloon is crossing without any difficulty. I mean, it went in pretty easily just on the first shot, too. And we had
I took it to 20. It's nominal at 12, which is 175 balloon, and then rated burst at 20, which takes it to roughly 19.
So should we take a little picture there, just see what we've got?
Sure. Before I take the catheters out, I always do that little puff, a little perf check, just to make sure everything is good before I take the balloon entirely out of the guide and then wish I had it still in the guide.
So, taking the IVUS back now at this point will really kind of help our the next part of this decision in terms of the next strategy, whether it's atherectomy versus IVL or something else.
I notice on your table there's not a hint of hemoglobin. I'm really impressed with that.
Mighty clean.
Yeah, we're OCD here. Lovely. All right. So we've got you on IVUS Live here, and we're going to record and pull back.
And you also saw how easily the IVUS catheter crossed, so that's kind of helpful. We'll bookmark that distal segment there and go back to that.
I wonder if some element of that is bridging too.
Maybe. Eccentric there, not 360 there by any means. 180 there. There's work to be done there. There you go. That needs some work. And there, of course, that needs to be addressed too. So very useful. I mean, very helpful to understand what we need to do next. So let's see. I guess votes for atherectomy versus IVL would be the discussion here, right?
Yeah. And if atherectomy, which type? And what burr size if you're doing rotational?
Oh, the proximal LAD is going to be a much larger vessel.
Yeah, let me give you some sizes.
Pre-dilate to 175, right? So I guess I would choose IVL or orbital. So
I've probably got a 3-5 vessel distally, and then
I think that's that area of plaque stenosis
Just
that didn't look so
4.
calcified.
just over 4 there, and then that's the really tight spot, and then that's sort of,
We measured the origin close to 4.5.
yeah.
Yeah, interesting. Before you did this IVUS, I would have said rotational atherectomy, but now that you recognize how focal the circumferential
Yes.
segment is, I think it is much more amenable to IVL.
Well, and this would be, as Prashant and I were discussing, if it is the circumferential as evidence that this is kind of the strike zone for intravascular lithotripsy of capitalizing on the acoustic effects of contralateral, circumferential calcification here too.
Yeah, and where it seems to be circumferentially calcified, it looks about a 2.0, so.
So I think, so if it sounds like we're leaning towards IVL, what size would you all use?
That's the $1 million question, my friend.
You've got the aneurysm there. Is the
I'll vote at
difficulty.
3.5.
I'm going to say 4.0.
What the rest of the...
I'll go with a 4 just because I have to do something different today, but I'll go with a 4.0.
Yeah, I mean, mostly you're going from the aneurysm back to the osteal LAD, and that's certainly all 4.0.
Yeah, I think 4 is reasonable.
So, Dave, what's the risk of perf if you choose wrong?
Higher than if you choose right. I'm driven a little bit by, I'm compelled to still a little bit by the smaller caliber of the distal segment.
Yes.
And I feel like, we can always go, rather than 6, we can go to 8, and do IVL if we need to, and maybe get a little bit greater acoustic effect. So I would, I'd err on the conservative side here of 3.5. If we needed to on the proximal side, we could always go a bit higher, but with another balloon, I'd prefer to just do this with one balloon, and just because there's more smaller caliber disease, a little bit more distal, I'd favor the 3.5 here.
My thoughts are with the, yes, go ahead, Cindy, go ahead, I'm sorry.
So the plan is to do both the mid and the proximal LAD with the IVL, not just the proximal 360 degree. Is that right, guys? Just checking
I think
here.
predominantly that proximal segment. I mean, we could hit. I think we could hit the more distal segment, but I don't think there's much calcium there based on the IVUS.
Yeah.
The other point I'll make is if you look at the IVUS screen right now, that's the sort of most concentric segment. And where the line that I've drawn there is 3.5. If you take that to 4, I mean, it would probably be okay, but I think a 3.5 would, as Dave says, maybe on the conservative side, but probably, comfortable as well. So this is a 3.5/12 IVL. And just to show that that's now crossing easy, just with the initial Scoreflex predil. So let's take a little puff there. You want to start there maybe?
Yeah,
I'll just do that. I don't think it's
do that.
calcified there, but
I don't think we're going to introduce a lot of harm there.
And we don't have to actually use the, although we could. You want to actually pulse there?
Let's see how it expands here. This is 4.
Yeah,
why don't
yeah.
you?
We're gonna do some therapy there. That proximal segment of the balloon did really expand.
And if you watch, you just see it open up.
I'm gonna fluorostate.
And we had a little bit of electromechanical pacing there too, if you watch our EKG wave.
So I'm just gonna replay that fluoro save if you
down.
can see it, and it did sort of just expand
Right there.
Yeah. So I'm gonna bring this back. The guide's coming in. I'm being cognizant of that.
The one issue too is Prashant's being really cautious not to let this balloon spring back too much, because then it won't go forward where we need it. So
I'm trying to hold the guide down as well. Yeah, I think that's come back.
That's good. That's good.
That's good. Yeah.
All right, you ready for this?
Yes, go ahead. So, and then just to sort of say it out loud, there is that small diagonal branch next to it. It's not particularly large. We felt it's going to be tricky to wire it. So we have not, but we'll keep an eye on it, and fingers crossed it'll do its thing. Stay open. Okay.
And down.
Yeah. Huh.
I think this is the majority of it right here.
Yeah, this is, we'll have to do a few more
Yeah.
buzzes here. Yeah, go ahead.
Prashant and Dave, just for the audience, can you sort of educate, you begin at 4, when do you go to 6? Do you ever go to 6? What are your thoughts?
So what I'm doing right now is I'm at 4, and then once we finish the cycle, I go to 6 and then come down. If it's a larger vessel like this one here, and I know that because it's tapering, I know that I'm undersized a bit, I don't have any issue going 6 here and then going to 8 as well.
I think the main thing you risk is if the balloon ruptures, you don't get to use the remaining pulses, and it's a very expensive device. So
Yeah,
I generally do most of them at 4, and at the end, when I'm pretty satisfied, go up to 6 and maybe finish.
Yeah, Don, that's been our approach too. We sort of do most everything at 4 and then leave it at that. Guys, same way?
So seeing that we had good expansion here at 4 and then 6, I did 6 and then 8 here, but I'm with you.
How many?
That's a fantastic demonstration of that first lesion yielding. That was just with just a few pulses.
Wait, let me get
early on, Rajiv, like after 3 pulses, and then it...
Go ahead.
That's good. Okay. And then it released. Okay.
Okay. How many? I can't see the shock wave. Can you see it, Dave? What's the?
We are 32, 31, 30.
Okay.
And then, so you got 3 more rounds.
3 more rounds left.
And down. And then I'd say, now, how many of you go back with a non-compliant balloon before stenting, or if you see balloon expansion, do you just go ahead and put a stent in?
Let me just come back a little bit there.
And I think that the guide is pulling quite a bit. I would assume that there's residual stenosis there that
I do too.
needs to be treated.
So what I do is I think we'll take a 3.5/20 NC on deck, and we'll get that ready just to go up. If you agree, Prashant.
Yeah, I mean the other point here is maybe we could always re-IVUS as well and just see if we see the fractures in the ring of calcium. Just to keep an eye on the time, I believe we have another 10 minutes left. Is that right, guys?
You have 19
20.
minutes.
Sorry, how many?
Yeah, 1948. You got all the time in the world.
All right.
Talk a lot.
We done?
Yeah, you want it to come out?
Yeah.
Let me just take a little picture here or a puff.
Yeah, go ahead, puff.
Or you can take the, yeah, there you go. Thanks.
So I'll ask my contrarian, Rajiv, would you IVUS at this point? Or
I think we're done.
You know what? I think it looks just a beautiful. I think you're going to use an NC at some stage, either now or after you stent. I guess I'd be tempted to put a stent in. I mean, all your catheters that you're putting in are flying down there. You're having to hold them back.
Yeah.
I'd probably go maybe stent, IVUS, and post-dilate according to the IVUS.
Would you
But
not
can do
IVUS
anything.
at this point, Rajiv, or you think we're set for a stent?
I think it's very reasonable to IVUS, Prashant. I guess on a Monday, Wednesday,
Let's go ahead
Friday,
and dilate
IVUS on a Thursday,
And then do it just
Yeah.
if we've got 20
I'd like
minutes.
to IVUS, give some
Okay,
vasodilators,
first.
IVUS, where I'm going to land the
Yeah,
stent,
Alice
what
will
the
help us.
diameter
We'll do
is.
it.
and
Pick the
length.
size and
So look if you let the LED plump up though already.
Yeah, distally it's a bigger vessel.
I think the
Yeah,
mid
it's a bigger
segment.
vessel, that's why you.
My guess is it's going to be
It's
it's going to be intramyocardial too. Is my guess.
Right, I would IVUS also, because the distal left main, I guess it's foreshortened and overlap there, but it doesn't.
Yeah,
look-
let me,
And
Cindy,
that
let me give you
aneurysmal
this view.
segment and
You'll
how you're
see
going
the
to
left
cross it
main
and
there.
cover it.
There, the left main is kind of, I think, relatively preserved.
There's mild, by IVUS, there's very mild concentric disease. The mismatch is, even though the osteo LAD is large, the left main is even larger, the size mismatch is a little bit formidable.
I think we'll record that.
Okay.
So we're recording, we're going to bookmark that. What is that, is that 4?
One, two,
no,
no,
And
too
to
close to
Dawn's
the
point, have
3.5.
you given nitro after you've got flow down there, your balloons, and now you're IVUSing, or this is?
We did not give any
not-
nitro, this is before nitro.
Go, do me a favor, Prashant, go even further down. Let's just look at this. Yeah, see this, doesn't that look like potential bridge there? There's some
Yeah.
plaque there, maybe
Maybe it's just
not.
plaque. But, relatively free. There's definitely some plaque there, there you go.
Yeah.
Yeah. Just looked angiographically so large, so I wonder if there's some kind of vasospasm
So
or
I think
constriction.
the normal segment is probably, that's not normal. Maybe somewhere in there. All right.
There.
Yeah, that
let
one
me just
side
puff
looks
that.
like it might be
Go ahead.
intramyocardial. It's small, it's
Now we're
smaller
coming up to
there.
the. Okay, so I think we see some fractures there at 12 o'clock, maybe. There was nothing there that sort of told me that we need to do any more debulking or plaque modification. You agree?
About 3.
Yeah, I think the question here is NC first and then stent, or stent and risk, stent, regret.
Right.
Depends how confident you are. The IVUS looks good.
Yeah, IVUS looks like we've made some progress here. So Dave, what do you think about a
The
3.5/20?
audience and I
I'd say let's just go ahead and do it. We'll
Yeah.
grab an ACT if you don't mind, and
Yeah,
then
I'll do
I'd say
that.
let's just go ahead and do it with the NC balloon,
Yeah.
just to ensure it looks good, but not by angiography, but not by IVUS.
Nothing worse than stent regret,
No.
right?
Yeah.
Nothing
Yeah.
worse.
Good point.
I think it is difficult sometimes to identify fracture, particularly in using this IVUS platform.
Sure, fair enough, Don. Reasonable. ACT on the back there for you.
Still no hemoglobin on the towels. You must be doing.
Yeah, he has
have
a
some
little
special
on
towels.
his,
No, see,
Well,
he's
here's the
putting
trick.
Yeah, look at his
Yeah,
arm, though.
here's the trick.
we're watching.
Your right arm, those.
Yeah, we've got this backstop here, and when we bleed back, we use that. So,
Whoops. Let those drop.
what was that?
Glasses. Go ahead.
Oh,
When
I don't want to step on them.
oh, that's fine. When we do these too, we have 7 different layers of towels, Rajiv, so you just can't see them because we quickly throw them off once they get dirty.
Like you're riding a horse and you take the goggles off every furlong.
What do we have? 3.5/20 NC Marge. Okay, so here we go. Nice. You want to start there? Let's puff that.
Yeah.
It's decent there. Okay, go ahead.
So just thinking ahead here, I got us a stent out, and I think we'll do a,
Nice expansion there.
that's 20. But it looked like by IVUS, we could go a little bit further with more disease, so something like a 38, do you agree?
Yeah, I think so. And let's come back a dot, because this is really going to be the main area that we're looking at now.
I think our
Go ahead.
caudal view is going to be a key one
Yeah,
also
should we go
to,
there?
well, let me go up here for now.
Go ahead.
I will be the one to position the stent too.
Oh, yeah, for sure.
So can I ask the panel, Dawn, you mentioned different modalities of IVUS, rotational versus digital. I mean, your comments on
Yeah.
preference in this type of situation?
3.5.
Yeah, I like the high definition rotational IVUS, and also you can get accurate length measurement with pullback. We don't have this system, but I'm used to it.
Don, I think the most important thing is, and I think you'd agree, but whatever type of system it is, or even whether it's OCT or IVUS, the most important thing is that you do it, that you use imaging. And secondly, I'm always struck by how familiar you become with one particular imaging modality. It's interesting, when I use other IVUS systems at other institutions, or we sometimes use a different one here for a clinical trial, I wouldn't say it's like starting over, but everything looks just so different than what my eye has become trained to.
So what did you guys choose in terms of size? Length, I thought I heard a 38.
Yeah, so this is a 3.538, Dave, 3.538.
Thank you, Prashant.
So we're in the right place. We're going to come into that AP caudal view to, understand where the LAD ostium is.
You want to start with a 4.0 in the mid segment then?
Yeah, I think so.
Can we get a 4.020 guys on deck? That looks pretty good, actually.
Yeah, and take a picture there.
Yeah.
Okay. What do you guys think? Do you go up there?
Was the proximal LED bigger than 5 or 5?
No, it's about 4.5.
Yeah, so I think you're fine landing anywhere then, because you should be able to get that position.
Maybe even come back a little. I think you went in a little bit.
Yeah,
Yeah, right there.
That's good, yeah. That's good.
Just being considerate of the distal end, I'm not going to take this too high. So we'll do 12 seconds there, or 12 for 15 seconds rather.
So what was the deployment pressure?
I just did it at nominal 12 atmospheres, Cindy, just because I know we want to go back and optimize the mid and proximal segments, but the distal edge by IVUS was more approaching 3 than 3.5, so I didn't want to...
Yeah, it's not much bigger than 3.5, if that. So I think the strategy to kind of go a lower rather than higher pressure there was the right one.
And then this is a 4.0 NC.
I'm going to come back to the cranial view now.
Do you want to do a 4.5 on the very front end or 5.0?
I think probably a 4.5.
Okay.
And then we can always, we'll IVUS to check, and then if we need to go
Guys,
higher.
can we get a 4.5 12 NC? This is a 4.0.
So what type of stent, and can it expand up to a 5.0?
Yes, this one, this is a 3.5. It will go to a 5. And hold on, I'll give you probably there. You good with that? I don't
Yeah.
want to go too far distance.
No, I don't think so either.
Yeah.
We discussed as well, so that diagonal branch, I'd say it's small, but it's not inconsequential. And this is 16. I'm going to stay there. And, the calcium in some ways protects the side branch. It would have been difficult to have wired de novo beforehand because of the calcium, and you'd have to have a big sweep on the wire to get around the calcium and then up into it. But I think it's hung in there nicely the whole time as well. This is 16 as well.
Well, that looks like it's expanded adequately. So what do you think, Dave? IVUS now and then decide on the proximal segment?
I'd say let's do the proximal segment. We've got the 4.5 already,
Yeah,
and
okay,
we knew it was at least that big by
Correct.
IVUS,
Correct,
and then we'll
yeah.
and then we'll IVUS.
Prashant, Dave, what tells you to go to 16 as opposed to 18 or 20 or Antonio Colombo 24?
In this particular case, Dave, a couple of things. I mean, 16 versus 18, I don't have any preference, but I see that I have definitely good expansion. I always still prefer to go higher than just nominal for a non-compliant balloon. Just I don't know, maybe that's the art of medicine and not the science, but I know this is a heavily calcified vessel, and I don't want to extend a spicule out or anything that's going to cause rupture. I'd rather, and further, I know I'm going to go back in IVUS. And so if I need to do touch-up work again, I can go back and do that with the 4.0 balloon.
Okay, another 2.
Yeah, there actually, back in the day, there was a trial that Bruce Brody did called the Post-it trial, and he IVUS'd in between various balloon inflations, and when he deployed a stent at nominal, 0% of them were nominal, right? And then it wasn't until you got into the 16, 18 NCs that it actually became nominal. So it was interesting.
But I think Dave's probably right? As we use IVUS more, and I think all of us are using IVUS more.
18.
Safety's got to be job one, particularly in these really heavily calcified vessels. The last thing you want is put in a covered stent.
It may be pinched, but it's still open. I mean, the other point to make with very heavily calcified lesions and post-dilation is the fact that, you know, we talk a lot about perforations and so on with atherectomy, but I would say that a lot of perforations that we see here is actually not necessarily, you know, with good technique, I think it's not necessarily at the time of the atherectomy itself, but it's with over-enthusiastic post-dilation of the stent. And so, you know, as long as you have good expansion in that position, it's reasonable. I think there's some, you know, it's worthwhile to not overly lean on these stents when, you know, this whole vessel is, you know, still heavily calcified behind it.
Well, you know, I think I've seen that when you tend to try to make bigger is better, right? I think it's over dilating, not necessarily the pressure, but the size.
Yeah, I was going to say, I'm more comfortable going 18, 20, 24 if I'm using 1-to-1 or quarter size up, half size up. But if you're a whole millimeter bigger, just to get the stent opposed to the wall, you don't really need to be going to 20 hemispheres.
All right, we've got IVUS for you here.
So low.
It's beautiful.
So that's the distal segment. Coming up to the mid now. Reasonable there. Good expansion there. And now approaching the proximal and ostial segments.
Ooh,
so,
that's a little undersized.
Or it just jumped there a little for us.
Yeah, there. No, it did for us too.
It looks like it needs to be a little bit bigger, proximally.
Right.
Yeah.
But
Although
very,
if you,
but very short
miniature, but
segment.
it looks at least 4 or 5, right?
I got to say, I think it looks absolutely outstanding from my
looks like
standpoint.
1,
It was
2,
always
3,
going to look
4
like
and a
that
half,
proximally. The expansion is just beautiful throughout. I think it's an outstanding. That's what you're after here. That's less an issue.
It used to be that we were so worried about malapposition, but I think in Gary Mint's most recent rendition of this, it was not malapposition, it was stent expansion that predicted, lack of expansion that predicted stent thrombosis.
Let's take a picture and we'll look
This
at it.
does seem, I think I would post-dilate this again. What does the panel think?
Oh, boy, you always ask me the tough questions, Cindy. I think...
So they went up to 4.5. What is it measuring? Is it measuring 4.5?
It's measuring 5.
It's measuring 5 to 5.2.
Yeah,
Maybe we'll go to the
I don't think you want to
AP
fracture the stent or anything.
You don't want to do that.
You're right, exactly. So you might, if you're gonna, you might, that's always the question.
I think if you could go back in time and look at this result at the beginning of the case, I think you'd take this in a heartbeat. I think it's an outstanding result. That's my considered view there. Really, really nice job.
I think that I would probably
in the mail
give
to you, Rajiv.
prolonged a P2Y12 though, if it's, because it's not going to endothelialize as quickly if it's not opposed well.
It's definitely opposed. It's just, you can argue, incompletely expanded. Yeah. I mean, still the luminal dimension is very large, but we elected just to go back with a really short 5.0 balloon, and we're going to, I think you can.
Well, Jeev and I are disagreeing on everything, so this is like working out fine, and we're really close friends, so.
So the darkness there over at 3 o'clock and 5 o'clock, you don't think that's media still? So you don't think it's lumen?
No, I think it was media.
Yeah, because it just doesn't transmit on the. So on our image here, we see it as media. But certainly on the screen, the feedback screen that we're seeing, that you're seeing, it does look like lumen, but the actual IVUS console here, it's not such.
Okay, gotcha.
Now, I'm just curious, would everybody IVUS after this, or would you say done it. I've taken the 5-0. There's no reason I was. Everybody
I would not re-IVUS.
I would not.
You would not.
No, what else?
I don't think you're going to
You know what I'm going to say then? Yeah.
I know.
I would, when Dave Cox comes back and does quality control on these angiograms, he's going to want to see that final picture. So I would read
Yeah,
this.
I would take an MLA measurement of your distal reference and your MLA of your stent and just confirm it's adequate.
David,
But it looks by the cold
David,
to
we
be
wouldn't
adequate.
dream of not IVUSing this.
expanded really nicely.
You guys truly have done a great job. This is a wonderful teaching case.
And the hemoglobin is going to be higher at the end of the case than at the beginning.
All right. We'll record again.
Did you want to IVUS?
No, I wouldn't have IVUS that. And Rajiv voted, it's just, I would not, I think they did a great job. I think it's
That's
nice.
a great expansion there. I mean, I'm not sure that we can
Yeah.
improve on that.
And if just go back to that and just for Cindy, whoops, I was just going to inject some contrast, Cindy, just to show you that that's tissue around there. Yeah.
Okay.
Okay, I see.
Perfect.
And how high did you guys go with the 5-0? I'm sorry.
I did 16 again.
Okay. That's a really good point, David. I appreciate you teaching me that you don't need to go to 22 on all these.
If you're going to image, then no. But if in a rare case, if I thought I couldn't get the imaging catheter down or something, I'm going to take advantage of high deployment pressures and everything as I can. I think I post-dilate 99.9% of everything myself in my practice, but and I use imaging in all cases as well.
200
But
nitro.
I did a case earlier today, and it was a very degenerative vein graft that was not a good native vessel CTO opportunity, and those are cases where I'll just try to do one single high deployment pressure stent. So in an effort to try to not embolize.
It looks beautiful.
Yep.
Yeah, we actually, we see more, interestingly, we see much more collateral filling to a codominant right coronary artery.
Yeah.
Yeah.
Yeah, it's a smaller artery, maybe even not that small actually. Now that we see that distal vessel, but it's the mid right is actually occluded in its mid segment. Here's the caudal view coming up now.
It's interesting in the segments that aren't completely circumferential, it just shows you where maybe where the fractures are and how the stent's conforming into the pockets.
Very good point.
So guys, it's 5:45. Are you going to do a same-day dismissal on this patient? Do you have a cutoff for time and observation?
Yes, we like to monitor them for at least 4 or 5 hours. So I think we will be in a position to do that.
Yeah, I mean, I think it's operator discretion, Rajiv, but if the patients especially live locally and they really want to go home and they have a family member that can take them, even if it's a late case, I'm all for letting them go home after a suitable period of observation.
You ready? So here's,
Excellent.
We're going to take a final couple of pictures. We typically do these same 2 views just to look for any issues. That looks nice. And then our final picture coming up here.
It's impressive you didn't see any malapposition at that aneurysmal area as well.
Yeah, we kind of normalized everything else to that segment.
It's so big.
Yeah,
So it looks beautiful.
fantastic
Great job,
results.
Yeah, so congratulations,
Yes.
Dr. Kandzari and Dr. Kaul.
Thank you all.
Okay, I want to thank Dr. Cox and my outstanding panelists for these live case
Nice job.
commentaries.
Thank you, Dr. Grimes.
Thank you.
Thanks, guys.
Thank you. Thank you.